So from here we can move into mobility testing. And we're going to look at both symmetrical and asymmetrical mobility testing, and we'll let the symmetrical tests lead us into the asymmetrical tests. So, looking at flexion and extension first. You'll be producing the movement via the legs, so it's important that the patient's legs are comfortable. Just one other word, if the patient really is very narrow-waisted, then you may want to put a pillow underneath here to support this so you don't allow this to side bend. Okay, to support the legs, bring the legs onto your hip, so you're not actually holding them up, they're sitting on the outside of your hip, and then hold around the outside of the tibia and not on the inside of the thigh. So we've got her into this position, and then I can produce flexion or extension simply by twisting my body in the appropriate direction. So I'll be palpating between spinous processes again with my fingers. I'll just move this down a tad, you can see it there, and I'll be moving up. So I'll be palpating between spinous processes and flexing and feeling for the superior one again to move away. And I can work up certainly to T12 without any difficulty at all. For extension, it's the opposite twist in my part, and now I'm feeling between spinous processes for these to close on each other. Now, as we did in the thoracic spine, it's possible to test the arthrokinematic of extension. And the way to do this is to extend the spine back in this direction, and then basically it's almost a compressive force through the tibia like so. And this results in the pelvis tipping in this direction and the glide occurring supro-anteriorly. But it's important that you get the full extension first before you try to glide this joint. My palpation for the fingers is in exactly the same position again, and this time as the glide is produced, I'm feeling for that inferior vertebra to slide up onto my finger. We can test rotation, and for this test I shall palpate again on the opposite side of the spinous processes to the way I'm rotating here, so that as I rotate the trunk back I can feel that superior spinous process move down relative to the inferior. I need my other hand, the moving hand, close into the palpating hand, and the arm that's actually going to do the moving is right onto the chest. So I'm spreading the pressure, if I can just roll it this way, across the whole thorax and not through a shoulder and not just with part of my arm. So in this position, I shall use my body to produce a movement by leaning across her this way. And I'm palpating that superior vertebra moving downwards. And as I move down, both hands move down together. So the force is localized to the level that I am testing. Again, if I have a reduction of movement here, I can test the arthrokinematic. Now, in order to do this, I will basically stabilize the superior vertebra of the segment that I'm testing by simply holding the spinous process down with my thumb, so it's well fixed down, while my fingers reach underneath the spinous process of the inferior vertebra, and then I shall simply draw the vertebra forwards through her trunk, not rotating it, but it's a linear glide through her trunk in this direction at the end of the rotation that's been available at that segment. The other test we need to do is side bending, and there are numerous ways of doing this. Probably the easiest way on both the therapist and the patient is to use the pelvis as the lever. You put your arm, the forearm, the fleshy part of the forearm, in the gap between the trochanter and the iliac crest, like so, and then put your body on it, because you're going to use the body to do the movement. And I'm going to palpate on the underside of the spinous processes, again between them, like so. So the technique is simply to lean into my arm that is on the pelvis, producing the side bending. And this is a nice, comfortable technique. There is no need to support anything, so the palpation is a good deal easier. And again, we're just feeling for the spinous processes to move onto each other. Thank you. Now, of course, you're going to have to move around the patient to test the opposite rotation and the opposite side bending. From this, as we found in the thoracic and the cervical spine, we can tell whether we have a symmetrical or an asymmetrical hypomobility, and we can treat it accordingly. If I find that extension, and in this case left rotation, is restricted, then I would be looking at an FRSL lesion for those of you, sorry, an FRSR lesion for those of you who use this particular type of terminology. If it had been flexion and left rotation, it would have been an ERSR lesion. In order to treat the combined movements, I will have to put her into the combined position, to the barrier of the combined position. So I'll just bring her back onto